Right. Yeah.
Live stream.
Why you use memory card? Yeah. You know, looking there. Why not see? No open? Yeah, you know nothing about phone. You stay there. I just have one of these. Like Galaxy Tab Paris. So is it?
What is status? Status information Android version 14. So we have version 11.
I don't know nothing about that. So what is this?
Give me that number phone.
I'm not talking about similar.
So that is started like in this guy.
They say look like one timer. I go all the way around.
No. I want to send this morning.
I do a lot of investigation because they we are far because they are times people want to at the same time
I want to just go no more. I thought I'm going to do something.
I'm always trying why the one go through also
Something then. I want similar something. I think that is them say. This is what is it? Right, see there. What are the music?
Next was the pre-mentioned
we have a request too, but more than I chat you request it.
Monday, September 13th. And special thought is
fever and more coffee and
now you can wait $80 for every 10 money. Get your money one thing, September 24.
You don't remember
For this afternoon and a one the monster winning once more. What will it be?
So yesterday, Sunday,
Cash for number 7. More topic and cash for selected for cash for 5 o'clock worth of more games is the afternoon.
Okay. Why you turn off the show? No. Hello everyone. Can persons check to make sure you're muted? Because we're hearing you.
some people have to stop that. So just where it's we're not going to chat. So we're going to copy you.
You need a day for the 10th coming? And from last year. Anyway, I need the next week. I'm pretty lady. Good afternoon. Yes, ma'am. Somebody up there. Here. I want today, everybody know. You know what you're oh, you're getting so easy. I'm going to just I'm guessing I'm from y'all already.
Here, but just try not to say chopstick.
Yeah, so that's what yeah, they get them for listening for the online. But yes, they don't. So,
Bobby gave you one.
Ten people? I wanna
It
do.
depends on who don't
I
know.
wanna do, yeah.
that sounds good. You prefer hanging out?
Ten people?
It's exhausting. Yeah.
One more time.
Many times comes you. Yeah.
Just one.
Free you can relax and do some other things. I will be available.
Okay, when you
And I'll go ahead. Not hearing.
Good afternoon, everyone. Thank you for joining early. We're actually doing some final setups because we're streaming live on YouTube as well. So we're doing some final setups here live, and then we will begin shortly. Are you hearing now?
Yes, we are. Thank you.
Bye.
Well, it's been pretty fantastic. So, until it is virtual.
Hello, good day.
Mean by the
All right, thank
that you try to so
Good afternoon and welcome to the Childhood Cancer Awareness Seminar. Let me thank you all for your patience, all our participants here face-to-face and online. Thank you so very much for your patience. We're grateful for your time and we are going to get underway. My name is Kedisha Watkis. I'm the Senior Public Relations Officer in the Ministry of Health and Wellness, and I'm happy to support the team in facilitating today's seminar. Of course, we are grateful for our partners who have also joined us, and we will be making them welcome at this time. And now that I've got that out of the way, let's get into it. So, permit me to give a special welcome to all our partners viewing us online and of course those who are here in person. And so we're thankful for the presence of representatives from the Early Childhood Commission and the Child Protection and Family Services Agency. We thank you so much for being with us today. And of course the team that is behind this seminar, headed by Dr. Tamu Davidson, Director for Non-Communicable Diseases and Injury Prevention Unit. We especially acknowledge you, Dr. Davidson, and your sterling team, and acknowledge all the hard work that you are doing in the unit. And of course, September is a heavy month for that team. And this is one of several initiatives that they're undertaking, a slew of events, a slew of activities for them in the month of September, and then October is coming up. So it's a special season for the non-communicable diseases and injury prevention team, but we thank you so much for all the hard work that you are doing. Permit me also to acknowledge from the Pan American Health Organization, Dr. Patrice Lawrence. Dr. Lawrence, we thank you so much for your participation. All of our experts in their various fields, representatives from the National Parenting Support Commission, the Nurses Association of Jamaica, the Medical Association of Jamaica, and the Pediatric Association of Jamaica, all our partners, we are happy to have your presence, whether in the room here or online. can't go on without acknowledging, of course, our medical officers of health. And we are excited to have you on board with us this afternoon. All our representatives across the 4 regions, 4 health authorities, the regional health authorities, we are glad to have your participation. Members also and representatives from our parish health departments. If you are online, we want you to acknowledge that you are here. Drop a comment in the comment section. Just represent the entity or organization that you are with and let us know that you are here. All our directors in the Ministry of Health and Wellness also, we thank you for all your support and your participation for today's webinar. All right, so we're going to get underway in just a few minutes. I have the honor of inviting remarks from 2 powerhouse women. Yes, I have observed their work over the years, and hats off to these ladies in health. So I'm going to invite at this time Dr. Patricia Lawrence from the Pan American Health Organization to deliver remarks, and she will be followed by, of course, Dr. Tamu Davidson, our Director for the Non-Communicable Diseases and Injury Prevention Unit in the Ministry of Health and Wellness. And so in that order, I welcome the remarks.
A pleasant good afternoon to all. Thank you, Madam Chair. Our organization were really not informed that we were delivering remarks this afternoon. So we don't have anything prepared, but just to wish everybody a productive meeting, and we're looking forward to the discussions. Thanks.
So we move right ahead, and I'll invite at this time Dr. Tamu Davidson to provide her remarks.
Okay, good afternoon, everyone. Salutations. And I'd like to just say protocol observed. But even with that, I would like to just acknowledge Dr. Shari McLean and Dr. Katie Mauricio. Sorry, Sharon, I'm still in high school, so I'm still using your McLean. Forgive me. We used to go to, I can take advantage. We were in high school together. It was just the other day, very recently. Yeah, we're recent graduates. Very recent graduates. So I'd just like to acknowledge them, and you'll hear further in the remarks as to why, but they have been very key leading this effort in terms of childhood cancer, and I just want to acknowledge them. We need to give them a round of applause because they're our key specialists at the Bustamante Hospital for Children. And so I'm happy to see one more key member on board.
Not hearing.
Good afternoon again. Welcome to this very important webinar in observance of Childhood Cancer Awareness Month. Today we came together not only to raise awareness on the clinical management of common childhood cancers, but to stand in solidarity with the children and families who face the difficult journey that cancer brings. The numbers are alarming. Every year, approximately 300,000 children worldwide are diagnosed with cancer. According to the WHO, the likelihood of surviving a diagnosis of childhood cancer really depends on which country you're in. And countries, low and middle income countries such as Jamaica, the survival rates are as low, less than 30% are actually cured, whilst in the higher income countries, 80% of cancers are cured. And we may be even higher than that as we continue to collect our data to see what's happening in our situation. But this is where we aim to get to in terms of really addressing childhood cancer, because we know we can do much better. In Jamaica, cancer continues to remain one of the leading causes of death among children aged of 14. But like the data, the stories are not just numbers, but there are stories behind them. And the stories behind them are far more than what we mention in terms of our numbers. These are our own children. They are full of potential, laughter and dreams. And see, we have a young child here in this room. And many of us are not so far away from those days of childhood and remembering those periods. Many of us are mothers. Some of us may be even grandmothers inside this room. And so we know what that means. So childhood cancer cannot generally be prevented or identified through screening. So this is why early detection and proper treatment are crucial. It is heartbreaking to note that many cases in Jamaica are diagnosed late, making treatment even more difficult. So this is why today's webinar is especially important, where we bring together our healthcare workers, and this is our second hosting of this major webinar. Not only our healthcare workers, but we also bring other non-health sectors and our key partners here today to listen to this lecture. And as mentioned earlier, childhood cancers, unlike many adult cancers, often arise from non-preventable genetic factors. However, understanding the signs and symptoms can lead to early diagnosis and better outcomes. So globally, the World Health Organization has the Global Initiative for Childhood Cancer, and that was established in 2018. And that is bringing all the different stakeholders, not just health, but other sectors together to really improve and increase the rate of survival for children. And so we have this global commitment and goal to increase the survival rate of children with cancer globally to at least 60% by 2030, which is just around the corner, 5 to 6 years from now, while reducing their suffering and improving the quality of life. Recently, last year in 2023, we and many other countries within the Americas agreed to the policy on prevention and control of NCDs in children, adolescents, and young adults. And that was a major turn for us because that also including cancer and other NCDs and recognition of really the need for countries to address NCDs in children. And as a nation, we are committed to improving healthcare access to our children. And through the partnership with Bustamante Hospital for Children, the University Hospital of the West Indies, and other stakeholders, and we also benefited from our relationship with the Sick Kids Hospital in Canada. And they have done quite a bit of capacity building and working with us. Also, the Columbia University, their hospital team, also St. Jude's. So we have quite a few of stakeholders, including our major stakeholder is the Pan American Health Organization, which has been supporting these efforts. So we continue to strengthen our efforts to provide access to life-saving treatment, but we still have a lot of work to do. And so it's crucial that every Jamaican child, no matter their background, has access to this care and the care they need. So the emotional toll on families is immense. And that is why support is critical, not just from medical support, but also psychological and social support is important. Families need to know they're not alone in this fight. Services such as counseling and support groups can also offer them the strength to keep going. So to the brave families, children that face this journey, you inspire us each and every day. Your resilience and hope show us that true courage, what true courage looks like. And to the healthcare workers, advocates, and volunteers who fight this battle with them, we thank you for your dedication and compassion. So as we come to the end of Childhood Cancer Awareness Month, I ask each one of you to spread the word as we continue to raise awareness all year round about this very important topic. Raise awareness in your communities, but especially amongst healthcare workers and caregivers at all levels about detecting signs and symptoms of childhood cancers and ensuring timely diagnosis, referral, and treatment. So I charge you or invite you to listen very carefully and attentively. And I think we don't give out certificates to people who don't listen and participate. Isn't that correct? Yes. So a ticket, you have, the ticket is you have to listen and participate for you to get that certificate. Please ask all the questions you want. And I am also charging you, once you get that recording, to just share it with another healthcare worker, one other healthcare worker, or non-healthcare worker, but please share it with another healthcare worker, because together we can beat childhood cancer. We can give our children give children living with cancer a fighting chance, a future, and that is full of promise, and let them continue to fulfill their full potential. Thank you. And we're looking at the numbers. You cannot earn that certificate if you're not listening. So thank you, everybody. And over back to you, our host and chair. Thank you. Yes, we just like to apologize for Dr. Lawrence Williams. She was not slated to give greetings, but we do appreciate that she's here with us online. Thank you.
Thank you, Dr. Davidson. And of course, echoing some of your remarks, it is in fact a critical conversation for the healthcare community, the child care community, but also for families and the nation at large. And so we're urging you, once we have completed the webinar, please share with others who can benefit from this conversation. So we're moving right ahead into our keynote presentation. And I want to encourage you, as Dr. Davidson has said, to listen, to participate, ask questions, because we will have a robust question and answer section following the presentation. And So we ask you to make sure that you are completely attentive. So I have the honor of introducing Dr. Kadeen Origio. Dr. Kadeen Origio has dedicated her career to advancing pediatric healthcare in Jamaica, having completed her medical training at the University of the West Indies, Mona, earning a Bachelor of Medicine, Bachelor of Surgery, and a Doctor of Medicine in Pediatric Medicine. Dr. Origio's passion for childhood cancer deepened during her residency at the Bustamante Hospital for Children, where she worked in the hematology oncology department. And of course, that experience propelled her to pursue specialized training in pediatric hematology oncology. Through the prestigious Sick Kids Caribbean initiative, Dr. Origio received a 3-year fellowship in pediatric hematology oncology and served at the renowned Hospital for Sick Children in Toronto. This fellowship allowed her to collaborate with international experts, gaining exposure to cutting-edge treatment methods and research in the field. Dr. Origio has recently completed her fellowship and has returned to Jamaica as a fully trained pediatric oncologist, working at the Bustamante Hospital for Children. And of course, we're asking you to give us all your attention, give all your ears to this presentation as Dr. Origio shares her passion and her expertise and shares with us on the future of childhood cancer care in Jamaica. So the presentation will be entitled Childhood Cancers, What to Look For. And we welcome you at this time, Dr. Kadeen Origio, with this presentation. Again, get your notepads ready. We want all of our participants, both online and in person, to be completely attentive to the presentation. We will have a robust question and answer section later, right, to be guided by another team member, but we, of course, urge you to give us all the attention possible so that we get those CMEs, right? Yes.
Not sure why that's not happening. Would you?
While we're fine-tuning that, I'm told that we have over 160 participants online. Over 100 and? Oh, well, 200. Over the 200 mark. We are so grateful for your time, your attention, your participation as we are getting things ready for you. Let me go ahead and invite you to tell us where you are from in the comment section. Represent where you are joining us from. There are a few other experts who I had not acknowledged earlier, or regional nursing supervisors. We welcome you. Or regional NCDs coordinators. We're so happy to have you as well. And of course, our pediatric medical officers, consultants, we're happy to have you joining us. And ahead of the presentation, here are some areas that we want you to look out for and to have comments ready for our question and answer section. So we want you to pay attention to the most common signs and symptoms of childhood cancer. So what are the signs, what are the symptoms that parents and caregivers should be aware of? We want you to pay keen attention to those areas, and we'll have the discussion following the presentation. Or public health departments, how can they collaborate with schools and community organizations to promote early diagnosis of childhood cancers? So we want you to begin thinking about these questions even ahead of the presentation. What kinds of collaboration can we look for in the public health departments and community organizations? And how about the role of regular health checkups? We want, of course, our children, our youth to have an active lifestyle and to be able to do all the regular health checkups. What role would these play in early detection, and how can we encourage parents to prioritize these? So we ask you to begin thinking about some of these questions. And how about barriers? What are the barriers to early diagnosis in our region? What is it like, not just in Jamaica, but in the Caribbean? What are the barriers to early diagnosis of childhood cancers? And how can we overcome them? And then finally, we want you to also think about your own participation, your own involvement in this work. How can healthcare workers, how can community advocates work together to support families emotionally and financially through treatment? We want to hear from you. And so we invite you to begin thinking about those questions, so that later on we'll have your responses. It's a crucial conversation. If you do social media, we want you to put this conversation online as well. Use the hashtag childhood cancer awareness. Hashtag MOHW. We want people to follow the conversation and to chime in. Snap a selfie at your computer for our online participants. Post a status, childhood cancer awareness. We want people to know what's going on. We want them to have all the information at their disposal. So we ask you to help us to spread this information, spread the word about this conversation that we're having. Invite other colleagues who may not as yet have registered for the webinar, but you know very well they can benefit from this presentation this afternoon. It's 2 continuing medical education credits, two CMEs. We don't want you to miss out on that. We don't want our colleagues to miss out on that either. So please do share as best as possible with other team members. All right, and so we are ready to move right ahead into our presentation. And for our online participants, if you're just joining us, welcome. You have not missed too much. The remarks from Dr. Patricia Lawrence from the Pan American Health Organization, remarks also from Dr. Temu Davidson, Director for the Non-Communicable Diseases and Injury Prevention Unit for the Ministry of Health and Wellness. And we are just about getting ready to move into our keynote presentation for this afternoon. If you have joined us from any of the following entities, we ask you just to indicate in the chat. If you have joined us from the National Parent Teacher Association of Jamaica, the National Parenting Support Commission, the Association of General Practitioners of Jamaica, the Council of Professions Supplementary to Medicine, please do indicate in the chat you are our special partners and we want to make special welcome and acknowledgements for you.
Good afternoon, everyone. Thanks for inviting me to do this presentation. As you know, September is marked as Childhood Cancer Awareness Month. Even though we are at the last day of our full month of celebration, we want to use this opportunity to just share with you some key points in identified patients who are showing early signs of childhood cancer. I know the month marked the end of celebration. However, fight for patients with childhood cancer do not end today, and we continue this fight throughout the years to come. So, next slide. So, what is cancer actually? Cancer is a disease in which some of the body's cells grow uncontrollably and spread to other parts of the body. So essentially, your body gives your cells signals, and all of us are made up of trillions of cells, and these are constantly dividing. Somewhere along the line, the signals for our body to divide, something goes awry, and these cells start to divide uncontrollably and no longer listens to the signal that is coming from our body. Cancer can start anywhere in the human body, which is made up of trillions of cells. Normally, human cells grow and multiply to form new cells as the body needs them. When cells grow old or become damaged, they die, and new cells takes their place. How does cancer behave? So what happens with cancer is that they grow in the absence of signals. So it's like you're at a stoplight, there's green for you to go, and there's red for you to stop. Well, cancer cells, they no longer listen to the signal that says stop growing, and they continue to multiply, and they may outgrow the normal blood supply of the body, or they may form large masses in the body. They ignore the signals, they continue to multiply, and they invade other adjoining or surrounding structure. For example, they can grow into organs that are near or adjacent to them, and they can also invade what is called the lymphatic system or lymph nodes, or they can spread to other areas of the body such as your bone marrow, and that's where the factory is of where your cells are being made. They also tell blood vessel to grow towards them. So usually our blood vessel carries blood to normal cells and carries oxygen and remove waste. What the cancer cell does is tries to trick those blood cells to say, hey, I'm here. Can you take nutrients to me and take away waste? So in essence, it's causing these blood vessels to treat them like normal cells. It also hides from your immune system. So usually what happens is that your immune system is very, very smart, and it usually is able to identify cells which are not normal or is not looking like the normal cells of the body. If something happens along the line where these cells for some reason looks strange, your body naturally says, okay, let me get rid of these cells, and we have a normal way of getting rid of these cells. With cancer cells, for some reason, they tell the immune system, hey, I'm normal, please allow me to continue to grow here. So that's what happens. Next slide. So as I said, it tricks the immune system into helping them stay alive and grow. It relies on different nutrients for normal cells. So it deprives your normal cells of getting nutrients. So for example, in our kids who needs nutrients for growth and development, you find that they become wasted. So they lose a lot of waste. They look what we consider mager. They look tired. They get tired easily because they just don't have the energy to go around and do normal activities for the day. They sleep a lot. You as a parent may just say, oh, why is she sleeping so much? Because all the energy that is needed for growth and development is now being used up by these cancer cells. One thing it does also is that it causes changes in our DNA. So our DNA is our backbone of what makes us up. So what happens with these cancer cells, it can cause these changes here and there in the DNA. So things that are supposed to look normal no longer looks normal. Some cancer cell makes energy from nutrients in different way than most normal cell does. And this also allows the cancer cells to grow quickly. So when a cancer cell grows, it makes a person weaker and it is more difficult to fight infections essentially. Next slide. Why is this such a big problem for us? So each year, an estimated 400,000 children and adolescents of age 0 to 19 years develop cancer. In high-income countries where there are comprehensive services, more than 80% of these children with cancer are cured. However, Jamaica falls in the low middle-income country where cure rate is approximately 30%. Most childhood cancer can be cured with generic medicine and other forms of treatments, including surgery and radiotherapy. Treatment of childhood cancer can be cost-effective in all income sectors. Next slide. Avoidable deaths from childhood cancer in low middle-income countries result from different things, and these include lack of diagnosis, misdiagnosis or delayed diagnosis, obstacles to accessing care, abandonment of treatment, death from toxicity, and relapse. Only 29% of low-income countries report that cancer medicine are generally available to their population compared to 96% of high-income countries. And I just want that to sink in a bit to show the marked disparity between access to care in our low-income country compared to access to care in our high-income countries. Childhood cancer data systems are needed to drive continuous improvement in the quality of care to inform policy decision. So, next slide.
Yeah.
Sorry for the pause, we're just having some technical difficulty with projecting here. Okay, so this map is a global map which is showing the distribution of cancer in patients 0 to 14 years in 2020. At the top is the blue, which shows the incidence of childhood cancer, meaning how many cases are being seen. And at the bottom is the mortality or the deaths associated with childhood cancer. What I want to drive home from this map is the stark difference in incidence compared to mortality. The area with the highest incidence is the area with deep blue. So you notice that in areas such as North America, Europe, and lower incidence is seen in like your African countries and South America. But what you notice is that the area with bright red is the areas where there's an increased mortality associated with childhood cancer. And this drives home the point that in a high-income country where they have a large accessibility to different resources, the mortality rate is far less than that is seen in your low and middle-income country, which is reason why it's important for us to detect cancer early in our children. Next slide. In 2022, more than 275,000 children and adolescents aged 0 to 19 years were diagnosed with cancer worldwide, and more than 100,000 died from cancer. However, the actual number is likely to be much more higher because countries in the lower and middle income settings, the rate of reporting is far less because of limited access to research in those areas. And this map also further drives home the point of the stark differences in areas where we have a larger incidence of childhood cancer compared to the mortality associated with childhood cancer in those areas. Next slide. Over the years, though we've seen an increased incidence in childhood cancer, the mortality rate continues to decline. But this is data out of United States of America. This is not quite so in our setting. Next slide. So let's take it home to Jamaica a bit. In 2024, which is this year, our estimated population was just under 3 million at the middle of the year. And it's equivalent to 0.03% of the total population of the world. And what I want to note in this slide is our pediatric population, more so 0 to 14 years old, where we see a large number of our patient population does fall into that category. Next slide. What we note is that just under 1 million young people, 1 million of our population falls into the under 19-year group. So that's just something to take home, because with pediatric cancer, we classify our patient as pediatric from 0 to 18. Other places go up to 21. But in this graph, they only look at patients, they broke it down into under 15. So we'll just take a look at that and see that about 1 million, which is just about a third of our population, is at risk of childhood cancer. Next slide. So for Jamaica, information is not readily available on the rate of cancer death in children. The National Cancer Registry, for the most part, focuses on adult cases. Over the years, we've tried to get a pediatric cancer registry up and going, so that's still something that's ongoing. Because of the fact that we have limitation in our resources and what we can offer here, we cannot adopt to all the changes that are seen in the high-income country. So things like readily accessible care, such as newer innovative therapy, immunotherapy, bone marrow transplant, that is not readily available in our settings. And what makes us unique as a group of people as well is the fact that we have a mixed gene pool. And our population is quite understudied. We have cultural differences and education specificity that will also cause disparities in our patients. At the Bustamante Hospital for Children, we admit approximately 35 new cases of cancer each year. And of note is that these patients are among the sickest patients in our institution. They have high needs, whether these are needs for medication, nutritional care, or social support, and require access to very expensive services such as diagnostic imaging, operating theater time, medication needs such as chemotherapy. So these are quite expensive. So it does take a large part of the budget. We rely heavily on the goodwills of our non-government organization and also structured MOUs that are brokered with other partners. So this bar graph, I wanted to highlight our cancer population, where we know that most of our pediatric cancer patients are usually between the ages of 1 to 8 years, with most of our patients actually fall in between the 1 to 4 year group. And this is quite concerning because these are patients who are in their developmental year. So imagine a patient like these being continually admitted to the hospital, being taken away from their family, taken out of the family, admitted to the hospital. They require quite intensive support, not just medication, but also social support is indeed necessary in this patient population. And this just shows the distribution of cancer that we saw at Bustamante Hospital for Children between years 2011 to 2015. Most of our a large number of our cases do come from the Kingston and St. Andrew area, but you see where we have patients coming from as far west as Westmoreland. We also have a great distribution in the St. Catherine and Clarendon area as well. So the mortality trend in patients under 5 and under 1 year has slowly declined over the years. However, we do want that graph to continually trend downward to 0. Just wanted to bring us back to the comparison between our low-income and high-income country, where we see a stark difference in the survival gap. We see where the survival of our low-income countries is hovering in the region of 30%, while in the high-income country, this is slightly trending up to 80 and above. So, having heard all of that, what are possible causes of cancer in children? So, for the adults, we attribute most cancer to lifestyle changes, environmental factors, but this is not quite so in children. We don't usually have those modifiable factors that we can say, okay, you change your diet here and there, it decreases your risk for this cancer. Most of our cases, the underlying cause is actually unknown. We do know that there are some genetic factors or familial factors that may contribute to anywhere between 8 to 10% of our cases of cancer. For example, cancer of the eyes called retinoblastoma, and I'll go through a list of other conditions in a few which we do see genetic predispositions with. Screening in general is not helpful for childhood cancer. However, it can be considered in selective cases in high-risk population. Genetic causes of childhood cancer are relevant in only a very small population of children with cancer. And it brings us to this list. And it just highlights some of what we call syndrome and cancers that may be associated with this. And I'll take the first one because I'm sure many persons will know someone with Down syndrome. So a patient with Down syndrome have genetic abnormalities, and they are at risk for leukemia, more so acute lymphoid leukemia and acute myeloid leukemia. ALL is also one of the most common childhood cancer seen. So we do know that these patients, we have to monitor their blood count to make sure that there are no changes that we're seeing that could predispose them, that could that we can see early for detection of childhood cancer. We also know that in the earlier infancy period, we can see changes in the blood cell in patients with Down syndrome. And these are patients that we have to follow up closely because it does put them at risk for developing AML later on in their early childhood. The other syndrome that I want to make mention of is neurofibromatosis. So I'm not sure how many persons actually know what this syndrome is, but usually patients have these abnormal growth of tumors on the skin. So it's quite obvious when you see these patients. Now, a lot of time it's quite obvious that this patient might have neurofibromatosis. So this is a second group of patients that may be at risk of developing a special type of cancer called optic nerve glioma. So it's a tumor growing on the nerve that supplies the eyes. So for example, you have this patient in your clinic and they start complaining of changes in the vision. It is important that they be referred on to an ophthalmologist for assessment and also to do neuroimaging, a scan of the brain to see if there's anything there that we need to intervene early. Because if it's not detected early and started treatment early, then it can lead to blindness. All right. So this takes us to some of our common pediatric cancer that we see. And I wanted for you to look at the blue, the area of blue on the right, where that is representative of your leukemia population. So leukemia is the most common childhood cancer that we see. And this is followed closely, well, not quite closely. This is also followed by your brain tumors. We also have our fair share of what we call sarcomas or soft tissue tumors. We also see tumors of the kidney or nephroblastoma, as well as tumors of the eyes called retinoblastoma. So pediatric cancers are quite varied. They may be just cancers of the immature developing cells, or it can be cancers of your white blood cells or cancers of solid organs. So it's important for us to monitor our patients closely if there are any changes that we're seeing in our well clinic visits, so that we can refer early and do early interventions. Here is also a bar chart representing the distribution of different childhood cancer in different areas of the world, where we see the areas of blue representing leukemia still account for a vast majority of childhood cancer. And of note is that with leukemia, our patients may present with simple things such as an aching bone. They may present with prolonged fever, which just won't go away. They may have like a viral illness, the fever goes away, then it comes back. They may have recurrent they may have weight loss, they may have night sweats. So these are things that we can look out for. And I'll get into those signs and symptoms in a few slides later. Why do we need to diagnose early? As I mentioned earlier, in our setting, we don't have the availability of some of the resources, well, most of the resources that are available in high-income country. So we have limitation in how early we can diagnose it due to accessibility of your imaging studies. We have limitations in the type of treatment that we can give, with limiting us to things like just surgical care, radiation, and chemotherapy. And we also have limitation or unavailability of our newer agents that have been developed over the year. We don't have ready access to bone marrow transplant in any of the English-speaking Caribbean. We don't have access to what we call immunotherapy, which are newer drugs on the market, which kind of target specific cancer cells. So we need to find these patients early, diagnose early, and try to prevent patients from presenting at an advanced stage of illness. Cancer is more likely to respond to effective treatment when we identify early. It results in a greater probability of survival. There's far less suffering. Imagine a child presenting early may not need as intense of a therapy as one who presents with cancer which has spread beyond the organ that it is in and has actually invaded other structures. and is often far less expensive and less intensive treatment. There's also significant improvements can be made in the lives of children with cancer by detecting cancer early and avoiding delays in care. A correct diagnosis is essential to treat children with cancer because each cancer requires a specific treatment regime. There's also limited resources available in Jamaica and inability to offer other layers of care and more intense therapy that might be needed in advanced disease. So, in childhood cancer, timely diagnosis and treatment are key to improving the chance of cure. So it's important to be aware of childhood cancer signs and symptoms. And what do you look for? There are different red flags that we need to look out for that may suggest or indicate early childhood cancer. And they may be hard to recognize right away because they may mimic just common illnesses. So patient may have prolonged fever or recurrent fever that may be attributed to another illness. They may also have aching bones. For example, that may be attributed to just growing pains in the younger children. Children often get sick and have bumps and bruises that might mask cancer. What I need to point out here is that lumps are bumps that are in a region that are prolonged after treatment, remaining after complete resolution of other symptoms. For example, a child has a cough or cold and have a swelling in the neck. 2 weeks, 3 weeks after the symptoms resolve, you notice that that lump is growing, it's not going away. That is definitely concerning. Go back for me, please. Cancer in children is not common, but it is important that you have your child checked by your doctor if they have any unusual signs or symptoms that do not go away. So the American Cancer Society has these guidelines to just help us look out for some of these warning signs. And it is continued unexplained weight loss, headaches with vomiting, especially early morning vomiting, increased swelling or persistent pain in bones or joints, sometimes accompanied by a limping, lump or mass in the abdomen, neck, or elsewhere, development of a whitish appearance in the pupil of the eyes, and I'll show a picture of that in a few, recurrent fever not caused by infection, excessive bruising or bleeding, and noticeable pallor or prolonged tiredness. So this is just a pictorial representation of all those signs and symptoms that I just went through. Just remember, weight loss, significant weight loss, headaches, persistent prolonged headache that's just not going away, especially those associated with vomiting, is a reason for you to be concerned as a parent, as a teacher in the classroom, because you may be the one who's interacting with a child on a daily basis, and this might just be dismissed as a child not wanting to come to school and is always complaining of headaches, but these things need to be taken seriously. So this, in South Africa, they use this mnemonic. I think it might not necessarily be useful, that helpful to us because it's Siluan. I'm not sure how much of us will remember that ever. So you can just continue on with the next slide. And what it said, S, seek. Seek medical help for prolonged symptoms. Should your child receive treatment and the symptoms don't go away in complete treatment, seek treatment again. If it means going back to the same physician who would have seen this child so they have an idea of whether or not the symptoms are progressing, are they getting better, then that's important. Get a second opinion if you think you need to. Your intuition for the most part is always correct. So if you go to a doctor one time, you go a second time, and you're not feeling comfortable with the outcome, seek medical intervention from someone else. There are the health centers available, there are the hospitals available. Walk into the emergency room. If the symptoms go away and then they come back, then that's an indication to also seek medical attention. Eye refers to the eyes, and a whitish spot in the eyes is something that needs to be looked into. A new squint, what we call cast eye, or new onset blindness, your child's complaining of not being able to see that when they look to the right, or they're not seeing the center properly, or bulging eyes, are all indication that need to be taken seriously, and you seek medical intervention early. So this picture refers to what we call, if you notice the top right, there is a white, what we call a white reflex in the eye, in both eyes, in the inner eyes on both sides. So what you gone back a few years back when we used to have those camera that has flash on it, when you take a picture, it would have a flash and you see the red reflexes in the eyes. So if you take that picture and you're seeing white instead of red, then it's indicating that there's something happening at the back of the eyes. So you take that child to be seen by your ophthalmologist urgently. Not 3 months later, but urgently. On the lower picture, it also showing the eyes turn outwards. If you and it's a bit white as well. So that's what we call a new cast eye, the eyes turning out. So that's an indication for you to seek medical attention as well. Lump. So it can be a lump anywhere. Lump in the tummy, lump in the hip, lump on the head, commonly a lump in the neck or under the arm or in the groin. A lump that is there, if these may be noticed, what we call wax and canal. If the patient have like a cough or cold, you can have wax and canal, which is swelling in the neck. These usually go away after resolution of your illness. So we usually give them about 2 weeks or so for them to decrease in size. They may not go away completely, but you notice obvious change with your other symptoms going away. If those swellings are not going away, they're increasing in size, then that's something that you need to check out. Also, you might be bathing your baby and you have an incidental finding of feeling a lump in the tummy. That's not something you watch. You take them into the hospital or to your pediatrician to be evaluated, and from there, they may make the necessary referral for investigation and treatment as needed. Unexplained fever for 2 or more weeks is a cause for concern. Unexplained weight loss and appetite, change in appetite. Unexplained pallor or paleness, because there's some condition that patients can present with pallor. For example, your patient with sickle cell disease may look pale, but this child is known to be well, and at age 4 just suddenly look pale for no apparent reason, then this is someone that you need to take in for evaluation. Unexplained purpura, or those reddish discoloration to the body. A child will play. It's not normal for them to get extensive bruising with playing. So if that's noticeable, then that's something concerning, as it might indicate a decrease or a very low platelet count, or which can cause bleeding under the skin. And if that is happening, then this is somebody that we need to do a blood count on to see what their blood counts are doing. And this can also help to clue you into a diagnosis, for example, of leukemia. Unexplained tiredness, bruises or bleeding, oozing from the nose or mouth is also concerning and needs to be taken seriously, and medical attention sought for that. Aching bones, joint, for example, and especially back pain is not common in children. So if your child is suddenly getting up one day complaining of significant back pain, they can't walk, they're limping, they're not able to go to school, it's not responding to your Panadol that you're giving at home, your Cataflam, then this is a child that needs to be evaluated by a physician. aching bones, joints, and easy fracture. Children are not supposed to be just playing and have a simple fracture. You're running and suddenly you're complaining of pain to the leg, and when you get taken to the doctor, they do an x-ray and they see a fracture. That's not common. That's signifying that there might be something wrong with the bone and needs further investigation for that. All right. The next thing that we want to look at is what we call neurological symptoms. Your child was previously walking, this 9-10-month-old, holding on, walking, babbling away, and then all of a sudden, over the last couple of weeks, you realize that he's just sitting down. He's not creeping. You put him to sit up and he's now toppling over, and this is progressively worsening. You have regression of your milestone. If there change or decrease deterioration in their walk, your 6-year-old who was not walking normally start walking with the legs wide apart and they're wobbling from side to side, and they're showing features of being imbalanced, then that's something that's concerning. If there's sudden change in the speech, there's weakness on a particular side of the body, or there's persistent headache, as I mentioned earlier, with associated vomiting, then that's cluing us into that there might be something happening in the brain that needs to be investigated early. A baby, usually when they come to the Well Baby Clinic, we check their head circumference to make sure that they're normal growth of their head. And suddenly, at the between 6 to 9 months, you saw this massive increase in size of the head circumference, just out of keeping with what you normally see. And you're seeing changes in the eyes not looking up or it's just persistently looking down, and the child is having consistent vomiting. Then this is also a red flag and needs to clue us in to investigate this child as well. For our physicians online and in the audience, there are different warning signs that might clue us into different medical conditions, and they're listed here. For example, as I mentioned, the bruises, joint pain, fatigue may clue us into a leukemia. The white discoloration of the eyes may point us to a tumor called retinoblastoma. Persistent swelling to the neck or persistent enlargement of your lymph node might suggest a lymphoma as well. So these are things that you can just bear in mind when you're looking at these patients that are presenting to you with new concerning symptoms. So what are some reasons for delay in diagnosis? So for cancer to develop, as I mentioned earlier, first, it stopped listening to the signal. The cells are abnormal, and it stopped listening to signals that tells it to stop grow. So it takes a while from that signaling for you, from you having those abnormality in cancer cell develop to you now having symptoms. So within that period, there's nothing that you can do to say, okay, I need to catch it in this phase. But from we have onset of symptoms to diagnosis of cancer, we do see at times delays in diagnosis of these patients. This is a tabular representation of some of the relationship between age and lag time between cancer diagnosis in children of different age group. And what we see that the lag time is in weeks. We see that in most of our, well, not most, there are quite a number of our patients, the earlier age group, we see that our parents respond much earlier. However, in the teenage years, a lot of time it's more so have to do with reporting, your children not coming home and telling you the things that are new to them. They're having concerning symptoms and they hide it. For example, a boy with a new mass in the testes, a testicular mass, he might fail to tell you that for months until it's quite obvious to you or his peers, and that's when he feels the need to now share this information. So it's as a result of patient reporting that may be attributed to the difference in the lag time between onset of symptoms in the earlier age group and the teenage age group. This also points to lag time between onset of symptoms for the different cancer. And I want to point out to your brain and spinal tumor that it does have quite a significant lag time seen there of anywhere between 1 week to 208 weeks. So you do know that between the onset of symptoms to patient present, that's a very, very long time. We do not want our patient presenting at 208 weeks. We want them presenting earlier. Earlier detection gives them a better chance of cure. So the survival chance of child with cancer in low and middle income countries is still a major problem and remains approximately 30%, whereas as I mentioned earlier, approximately 80% in your developed or high income country. In a research done in Ethiopia, which is one of our low income countries, the Ministry of Health and National Childhood and Adolescent Cancer Control Plan, it estimated about 6,000 childhood cancer cases are registered every year, and 80% die from their condition, which shows an extremely low cure rate. So as a low-income country, it points out to a greater problem, not only here in Jamaica, but worldwide, and the need for us to diagnose early to prevent or mortality rate being that high. So delayed cancer diagnosis, there are different issues that there are different factors that may contribute to patient presenting late. The child's age, as I mentioned earlier, teenagers may fail to report symptoms. Patient socioeconomic status, so you find that because mom and dad have to be out working, trying to get income to provide for the family, they may not have the monies readily available to take in patient to evaluate new symptoms. So that may result in delayed presentation. The parental education also plays a major role in that as well. So this also points to different factors different other factors. So for example, false belief is one of the things that still contributes to significant delay in presentation of our patient. They do feel that the child is sick, we just give them some bush, we just rub them up with the alcohol, bathe them in the Epsom salt, the symptoms will go away. Cancer don't happen in children. There are people out there that still believes that a child cannot get cancer. There are persons that come to the hospital and tell us that, doc, is the obia, we hear it so many times, and it takes a lot of time to convince parents that this is something that can happen in children, and it's something that if we intervene early can be cured. Next slide. So this is also showing the different reasons for delayed diagnosis. So we'll just move on from that. What are we seeing here in Jamaica in terms of delay in the diagnosis of our patients? So between 2016 and 2020 at the Bustamante Hospital, we look at the duration of symptoms prior to presentation for two different types of cancer. The neuroblastoma, which is a cancer of immature nerve cells, as well as Wilms tumor, which is a cancer of the kidney. And what we notice is that for the Wilms tumor, most of them usually present in less than 2 weeks. And what is striking here is because Wilms tumor commonly presents with a mass. So you will feel something as a parent, and most times it's an incidental finding. Meaning you're bathing the child, you touch the tummy, you feel a mass there. So a lot of time, which is a good thing here, you can actually feel something, and it can be shown to you that, hey, there's something wrong here. A child who has a neuroblastoma, who might just have non-specific symptoms, they are having a lot of prolonged fever and things like that. We see that their presentation times is usually greater in excess of 4 weeks. And a lot of time you have to imagine, I'm not seeing anything physically happening to my child except this fever, which can be just a viral illness. So this can be cancer, so I'll continue to watch at home. We also point out here with our patient with Wilms tumor or renal tumor, between 2016 and 2020, we noticed that of our total number of patients seen, it's almost a close split between those presenting less than 4 and greater than 4. And something to highlight here is Wilms tumor is commonly seen in your patient up to 5 years of age, more commonly around the 2 to 3 year old mark. So with our patient presenting around the 4-year mark, we're kind of capturing them early as we want to. The next cancer that we want to point out here is retinoblastoma, which is cancer of the eyes. And this commonly presents in your patient who are less than 1 or within the 1-year-old mark. And they usually present with that white discoloration of the eyes. So these are the patients that when they come to clinic, I know the doctors, you use your ophthalmoscope, you look in the eyes, you see if there's anything abnormal there. If you see anything concerning, you refer the patient on. When a baby is born, it is expected that we check the reflexes in the eyes to see if we're seeing that nice red reflex. If the baby is born and you're not seeing that, then this is a baby that needs to be referred on to the ophthalmologist so they can put the baby to sleep and do a more detailed examination, because this is not something that we want to miss. For the most part, retinoblastoma, if it is localized or is within the eyes itself, or it's just a tiny spot in the eye, the baby may not require intense therapy. But for example, if it's left untreated and it grows and it causes changes such as bleeding in the eyes become bulging outwards, or it grows into the nerve of the eyes, or spread to other parts of the body, then this patient may require more intense therapy such as chemotherapy. So you can early presentation where it's just a little tiny spot in the eyes, or ophthalmologists do a very good job at doing what we call laser therapy or sclerotherapy or things like those to just control that, as opposed to a patient presenting at more advanced stages of disease and spreading outside the eye. Then that is definitely concerning, because this is a child who definitely might need that eye removed. They may have to get prosthesis of the eyes. They will need chemotherapy to spread to other parts of the body. And in our setting, if it's extensive spread, the chance of cure become less, because we might not be able to give them as intensive chemotherapy regime or intensive treatment that is needed to offer cure. So it's important for us to detect early, refer early, so that we can have early intervention. What we do know is that still approximately 20% of our patients present with stage 4 disease, meaning that it has spread to whether the blood system, the lung, outside of the organ itself. And that for us is too late. We want to catch them early, intervene early, so that we can offer the best possible chance of cure. So what are some factors that lead to delayed diagnosis in our settings? Lack of awareness, financial constraints remains a big one that is seen for us. Even after diagnosis, with financial constraints, we do know that our patient may not turn up for treatment if we allow them to go home. There's delay in them coming back for treatment, and it gives the cancer a risk of coming back. They may have limited access to healthcare. So, as you know, there are only 3 pediatric hematologists, oncologists in Jamaica, and all 3 of us are in the eastern end of the island. So, children from, we do coordinate with our partners in the West to offer care at the Cornwall Regional Hospital and as best as possible at some of the peripheral hospitals. But for intense treatment, most of our patients have to make their way to Kingston for to access chemotherapy here, intense chemotherapy regime. And for those patients who you might assume are extremely unwell, would be better suited in the system, have to come into Kingston for care. And I left cultural and religious belief for last because that still remains a major sore point in our patient management. Still, our patient believe that the child will be cured from obia. Just allow us to go home, to give him a chance, to take him to the spiritual leader. And unfortunately, some of our patients abscond from treatment. If we send them home for a weekend or so, they just don't come back, and they come back in extremis when we're unable to do anything at that point in time. Yes, so this slide just highlights the different things that we've heard: the Leaf Alive, the Serosity, Epsom salt, rub him up with the alcohol. This will make him better. No. If you have concern about your child, that you took your child to the hospital for care, then obviously you know something is wrong with this child. Give us the chance to offer this child the best possible choice of cure. So there are also several myths surrounding childhood cancer that we need to demystify. We need to also help our patients in seeking medical attention promptly. A lot of persons, as I still don't believe that child cancer occurs in children. And as we've gone through the statistics, we've seen that it may be rare, but it's a pretty common problem that we encounter. There's also concern that, okay, now my child have cancer. People still feel timid in sharing this with people because they think that, no, my child is going to be seen as inferior. They're going to be seen as different. Cancer is contagious. So if my child has it, the neighbor might not want him to play with her because the neighbor child can get cancer too. Or it's something that our family did wrong that caused my child to have cancer. So in a way, they kind of keep this diagnosis in a box within the family, maybe just within the household itself, and not even the extended family, because of fear of sharing this information. And it's important that we as a community be open and be aware that there are these childhood cancer exists and offer as much social support to families in the community. You see a mother the child has been missing from home for a few days. You check in to find out what's happening. They might not be willing to open up readily, but just continue to check in to see how best you can help them. So let's jump into treatment. And I'm not going to go in detail about any medical management of our patients with cancer, but I just want to highlight that the team of persons who manage patients with cancer is quite extensive and requires a multidisciplinary approach. So you have your pediatric oncologists, which are medical doctors who specialize in cancer care. You have the pediatric surgeons who we need, if a child presents with a lump or a mass, we need them to go in and get a piece of that tissue, and then we can make our diagnosis. The radiation oncologists are the persons who give the patient radiation therapy as needed. We have our nurses. So we have trained hematologist oncologist nurses, and we have also our staff nurses who are a part of our team. The pharmacist is an integral part of our team as well because they are needed for dispensing chemotherapy. They check the drug with us to make sure the dosage is adequate, and they're also important in the mixing and handling of chemotherapy in a global setting. Our physiotherapists are also important because you can imagine our children come in and they're sick, they're weak. For some patients who need to have a limb removed, we need our physiotherapists to help with things like ambulation. Occupational therapist is also important. Unfortunately, we don't have one readily available in our public system. psychologist support, as you can imagine. This is all new to parents and to the child. So imagine breaking this news to a teenager as opposed to a child. You have to do it in different, in form which is developmentally appropriate. Us as doctors are not necessarily that that verse in breaking down things to different level. The psychologist is important in that area to help them go through and navigate, because this is breaking bad news, and you have to be cautious in how you provide information. We always encourage our parents to share the information with their children as developmentally appropriate as possible, and we can be there to provide that support. But you can imagine if a psychologist or a social work team is present, then that would also be helpful in navigating these new changes that they'll be going through. Or social worker, as I mentioned, financial constraint, remember, remains a major problem with diagnostic delay as well as access to treatment. So a social worker can somewhat bridge that gap with as much as they can to make sure that our parents and patients come in when they're supposed to provide financial support with transportation. They may be coming in and they can't afford the lunch today. So our social workers are there to help bridge that gap and make this as comfortable as possible. A child life specialist, which we don't have in our settings, a palliative care physician. So even though we try as much as possible for cure, we are cognizant that we are not able to offer cure for all our patients. So our patient will also transition and will demise. So that's where a palliative care physician is pretty helpful. So we know the stage of disease they have. We know the level of care that we can offer here. So what is done in such a setting is the palliative care physician is introduced pretty early, and they help to navigate that area of life. I should also hasten to mention that palliative care physicians are not only there for patients who pass away, but they can also help with other supportive roles such as pain management, because some of our patients might have intense pain and may not be responding to the drug that we're given. So palliative care support is important. They also provide somewhat of a social support and bridge the hospital and home setting. You have sibling in the home, those patients are also taken into consideration, both by the social worker, the psychologist, and the palliative care physicians. So our treatment of our patients with cancer may require different mode of therapy depending on the type of cancer and stage of cancer. Chemotherapy and radiation therapy we do have available here in Jamaica. Unfortunately, we don't have access to bone marrow transplant. And you can imagine there are some cancers that are more advanced, or the cancer may go away in terms of a leukemia and come back, and they may require more intense form of treatment, such as a bone marrow transplant. We don't have this readily available here. Immunotherapy is like this target specific proteins on the cancer cell to say these drugs are highly specific and not as toxic as or conventional chemotherapy. They are able to target specific cancer cell, which our chemotherapy are not that smart. So they target cancer cell and they also affect your normal blood cell. The immunotherapy and targeted therapy is more specific to the cancer cell. So even though they can have toxic side effect, it's not as great and as significant as we usually see with your chemotherapy. So that is definitely where we need to be headed, but we do know that we have financial constraints. We have to do the most with what we have in our settings and try as best as possible to get these patients early and try to offer cure. So for patients with childhood cancer, just to reiterate that the entire family is affected. Cancer usually strikes when children are at a young age. The parents are a lot of time often young as well. They might just be navigating life themselves, and they may also have smaller children or other children at home. Sometimes both parents must stop working in order to care for the sick child. So they need to alternate who's taking the child in for treatment today. So those things have to be considered. So there's a loss of normal life. There's disruption of school. There's disruption of your social life. And there's disruption of work, and there's significant financial loss. On the patient itself, chemotherapy, treating cancer itself makes you feel sick. And treatment given for cancer, chemotherapy and radiation, does similar things. So you will feel sick. There may be associated nausea and vomiting. So you may come in for nausea and vomiting, and the medication that we're giving you can make you nauseous as well. They can have decreased appetite, just tired because of the drugs that they're on, because we're giving chemotherapy that's not just affecting the cancer cell, but it's also affecting their normal cells as well. There's changes in physical appearance, and this is especially important in our teenager. The hair will fall out. It's almost 100% sure that their hair will fall out, but for them, it will grow back. All right, so you can imagine a teenage girl. She doesn't want to go on the road because she normally have a long flowing hair, and now she has a bald head. She becomes conscious of her physical appearance. It has emotional effects. So imagine a teen going through their usual teenage years, and they are quite moody at the effect of being treated for a chronic illness on top of that, something that you have to deal with. You have to deal with all the side effects of these drugs. They're making you feel sick. They're changing how you look. You've lost a lot of weight. The hair has fallen out. You don't want to be seen by your friends. So put that all together, the emotional changes that can be encountered in this age group. It's also seen in our younger children, because we do give medication that can cause mood changes. For example, if we give them steroid as a part of our treatment, it can cause temporary mood changes. We can think about this long-term psychological effect that it has on our teenager, and how this can affect how they perceive themselves. There's also increased susceptibility to infection, so you find that they might not be able to be as social as they want to be. When we tell them your blood counts are low today, you can't be out partying, you can't be out with your friends, your blood count is low, you need to be admitted and given transfusion. So things like those can definitely take a toll on our patients. So as many as 2/3 of our survivors will have, in the US, this is a reported incident, will have at least one chronic health effect. Because as I mentioned, chemotherapy affects normal growing cells as well. So we do know that in the long term, we have to follow these patients to look out for long-term side effects. It can affect the heart. It does some chemotherapy agent predispose them to developing second cancer. So we do have to monitor for that. 25% of survivors have severe life-threatening effects, and 10% will develop secondary cancer. Follow-up care is crucial. Parents, follow-up care is crucial. And what we do know that when a child finishes treatment, a lot of parents throw their hands up in the air and say, yes, they're done. No, they're not. We have to monitor them long-term. We have to monitor them for any recurrence of the disease. We have to monitor them for this, the long-term effects that can happen. Next slide. And I'll mention these long-term effects include delayed or disruptive cognitive development. So they might not develop a child their age group, so we may have to make special referral. Stunted growth, you can imagine a child with a brain tumor, they're doing surgery in area of the brain. There is a tiny gland at the base of the brain which can control the growth hormones. So if we're giving radiation or anything in that area, then it can affect these hormones that control growth. So we have to monitor them. We have to make sure that they're developing normally. And if they're not, we make appropriate referrals. So don't sit at home and watch and say, well, treatment done, I don't have to go back to the doctor. You do have to continue follow-up. They can have learning disability. They can have infertility issues depending on the dose of medication that they get. For example, a teenage girl who has ovarian cancer and have to remove the ovaries, or a boy who has testicular cancer and have to remove the testes, then there are the reproductive challenges. Also, if we give specific chemotherapy that can affect your sperm cells or your then that can also have long-term effect on family planning. So those are things that we have to take into consideration. We also have to think about our patient who have to undergo things like amputation, or patient with a bone tumor who have to remove a leg or arm. They are going to look different. They may be physically handicapped, so they have to know how to reintegrate into society once they've completed treatment. So in 2018, the World Health Organization launched a global initiative for childhood cancer with support from St. Jude's Research Hospital and other global partners. And the initiative has the goal of achieve at least 60% survival for cancer globally, not just US, not just Europe, but globally by 2030. And our aim through this is to improve cancer care and decrease the associated mortality and morbidity associated with cancer treatment. Next slide. What can you do what can we do to help with our patients with cancer? Help your community become more cancer aware and more supportive of local families and children who are fighting this devastating disease. Volunteer for a childhood cancer organization. Start a support group or outreach organization. In the schools, this is especially important. The child will be out of school for a very long time. So as long as the parents are okay with you sharing information with the class, making them aware that the child will be out for a while, but they will come back once they've completed treatment. You also have to prepare the class for a possible death in that case. So it is important that you present information to the children in the class setting in a developmentally appropriate way. If the child was sitting in a specific area, in a specific desk, leave that desk available as well so that it doesn't feel like they're completely left out from the class. Still call their name in the register on a daily basis so that the children in the class remember the name of this child who's not there and think about the fact that they may be rejoining the class at some point in time. Prepare the class that when the child comes back, they may look a bit different. Educate our children, because we do know that children can be a bit mean. They may bully each other. So prepare them for the changes that they may see in this patient when they come back. So what can we do? Look out for the warning signs, seek medical attention, and refer. Advocate for students, patients, and for your child. Get everyone on board. Form collaboration with a non-government organization, with the school board, get people involved as much as possible as we try to make people more aware of childhood cancer and the fact that early diagnosis can prevent decreased mortality and morbidity associated with children. I just wanted to mention the Sick Kids Caribbean Initiative, which has been very instrumental in helping us with diagnosis and treatment of our patients with cancer. They offered educational support. They offer continuous consultation, as well as diagnostic review of diagnostic imaging, secondary testing of samples, which is not readily available in our settings. So we need not only outside organizations to be on board, but we need to get more for local organization on board to help in the fight against cancer in children. So target care, we need more people. I should have mentioned this earlier. Blood donation is essentially important for patients with cancer. from treatment, their blood count will be low because of the toxicity of treatment, toxicity associated with treatment. We need more patients to be, more persons to be donors for blood, not just when you have a family member that's sick, you post it on social media. Continuous donation of blood, make it a scheduled thing. Every 6 months you go in and you donate blood, because as it is right now, it's always a challenge trying to get blood for patients who we're treating for cancer. Help us raise awareness. That's one of the target points for today's presentation. Make everyone around you aware of cancer and its outcome and the fact that it can be treated and offer possibility of a cure if detected early. You can come into the hospital, you can provide support to the children, whether it be through care package, coming to do art day with them, coming to do story time, because you can imagine these patients are sick on the ward, they don't always have the social support to get and be integrated in a lot of things, so they, for the most part, are on the ward, and they would love and appreciate people coming in and just spending time with them. Donate, donate, donate in whatever form you can. We do need psychologists in our setting, whether or not it be persons volunteering for patients and their parent, but this is definitely needed. Invest in a family, adopt a child. Doesn't have to be an adoption that you go through paperwork, but just support the family in whatever way that you can. A lot has been done to advance childhood cancer in Jamaica, but a lot more needs to be done in the fight against childhood cancer. And that's it.
Thank you very much, Dr. Origio. Wasn't that a good presentation? Now I'd like somebody to help me with online, because I want to see my online participants. I learned a lot today. I know those online also learned a lot today. We have 250 persons strong online, and we want to hear from them. So if you can just open the chat. Alicion, can you open the chat? And we are going to take a few questions for Dr. Origio, and we can also give her a mic, and we're going to take a few questions. Now, while you're opening the chat, one thing I want to see in the chat, one thing I learned this evening, do not watch it. Did you learn that this evening? I learned don't stay home, don't ignore the symptoms, and don't watch it. So I want my persons in the chat to say, don't watch it. I want to know that you're in here with us. I want to know that you're answering. We're going to type, don't watch it. Thank you very much. Don't watch it. Do not watch it. Excellent. I like the all caps, because we are not going to watch it. Now, this afternoon online, we actually have a wide range of persons. We have parents, we have children, we have persons from different organizations, and we also have medical practitioners. So everybody online, everybody in this room, we now know so much about childhood cancers. One thing I also want you to answer in the chat, what did we say was the cure rate internationally for high-income countries, and what's the cure rate for low-income countries? What percentage? Yes, I see it in the room. Yes, in the room?
Yes, 80%
80 and
international.
30, is that correct? 80 and 30,
80,
good.
80 and 30.
Can I see it in the chat? 80, that's right, 30 in JA. You're very good, very good. 80-30, I'm seeing it coming out. I hope it's not because you heard us, but you knew it. So we're seeing it, excellent. So those are the kind of take-homes we want everybody to have today. We all now know about childhood cancer. We know what is happening in Jamaica. We know how we're going to play our part. Now I'm going to allow anybody online. You can open your mic. Will we be able to hear them? Or they can type their question in the chat, and we'll read. And I'll go for the room. Do we have any questions in the room? Yes. Can we have a mic? Yes, I wanted the online to get ready, but I'll take in person. And then I'd love to see, we can probably stop sharing so we can see the hands being raised.
Testing.
Great. And we do have a question online. We'll come back to online. You can stop sharing. I'm not able to see, so if you stop sharing, it'll be a little bigger, and then I can probably see the participants. Excellent. You can make that chat wider. Awesome. So we'll go in person, and then we go over online.
All right. Good afternoon, everyone. Oh, just to underscore, great presentation, Doc. Yes, I must say. My vernacular is quite different, but you broke it down into quite understandable terms, and I really, really appreciate that. All right, coming from the early childhood level, I have 3 questions. It would have been 4, but you explained who is a child life specialist. So I'm just going to say it because I'd really want to make note. Sure. The first question, I'd like to find out if there are any policies or initiatives that are currently in place to support families of children with cancer, if you can enlighten me.
So currently, we have non-governmental organization on board. For example, at Buster, we do have the support of the Flow Foundation. They have been quite instrumental in helping some of our families who are unable to purchase, whether it be medications or, for example, a Portacath, which is a special type of IV access, which is a larger bore IV access. Instead of sticking the children on the arm, we use a larger bore and we insert it in one of the larger veins. So they have been quite helpful for parents who are not able to purchase these things. We can go through them to help access financial support in getting this. And I must also highlight that they've been also quite instrumental in helping our patient to just have as much support as possible through the Flow Foundation. Every year they would have some form of a treat, and more recently this was taken outdoors for a patient. So we do have support through them. We also have access to the Compassionate Fund, where we can apply for funding on grants for a patient, and through the government for patients who need to access care overseas. There's access through the Ministry of Health, where they do assist parents with providing some form of financial support that requires access care overseas that we're not able to afford here.
I want you to have a mic.
Right. So children who are on the PATH program, who are ill and need to have surgery, who may need medication, can also access funding through the PATH program.
Okay, thank you for that. Dr. Sharon McLean. So as well, there's a Chase Fund.
Yes.
Who has helped us a lot for the more pricey items. And that's not just in the public service, but also, I think, university and anywhere else that we have children who have those higher ticket priced needs. You spoke about Ministry of Health and International Arm.
Yes.
I want to also highlight the groups, the Optimist Club, Lions, Kiwanis. They never leave us out every year. But a lot of this is so important in making this work that we encourage them to keep us in mind and keep engaged. And we'd like to see more, because as Dr. Riggio pointed out, what it takes to properly treat involves many, many, many specialists, you know. PATH program is also extremely important. We have a lot of parents who bring us those slips to fill out so that they can get that support.
So we have another question? Yes. And then we're coming over to you in the chat. So go ahead and type in your other questions and we'll get to you shortly.
All right. Our question number 2, if there are any plans to enhance funding or mobilize resources for childhood cancer treatment support. For example, you had mentioned access to life-saving treatment. And I'm taking this from an early childhood perspective to say, like, when parents come to us, they come to us for so many different reasons. They want help with their child for funding, help for diagnosing their children, that kind of thing. So it's just to say, are there plans to enhance funding or mobilize resources so that we have some amount of help when they come to us?
So as I should highlight, in the public system, whether it be diagnostic imaging, chemotherapy treatment, that is all free of cost to all parents. Most of the costs to them will come from the traversing home and back, the cost for transportation, the cost for food and all of that. But the cost, there's no cost for chemotherapy, there's no cost for surgery, there's no cost for admission in the public system to the parents. But most of the costs will come outside of the area, the immediate area of treatment. But nonetheless, I think we need to also highlight that if they need to seek care overseas, that will definitely put a very, very large dent in anybody's, in anyone's financial situation, because as you can imagine, trying to access care overseas without adequate health insurance can be quite a burden to anyone.
All right, thank you. Are there any initiatives to improve the quality of life for childhood cancer survivors? Just basically, how is it that we can help to reorient these children back into their home or their environment? You had mentioned schooling, but I'm just wondering if there is any way that we could partner or draft like a MOA to say that with the schools, how is it that we can support environmentally?
So that is a great question, and I think we need to be targeting the ministerial level. It's hard for us to just be brokering things just at the Bustamante Hospital. This has to be at a larger level at the Ministry of Health, where we're not just targeting the group at Bustamante, but we're targeting all hospitals across the board to make sure that not just patients with cancer, but all patients with chronic illness are appropriately reintegrated into the they're appropriately reintegrated into the system once they've completed intense care and can get back into school. What we do is that whenever a patient is going to be out from school for a very long time, we write a letter to let the teachers be aware that they're admitted for chemotherapy. They will be away for a specific duration of time, and even when they come back to school, there may be intermittent days that they will not be able to come in because they have to come in to the hospital for treatment, or if they're otherwise unwell. And there may also be some limitation in activity there to what they can actually do when they're reintegrated into the system. So we usually guide those processes by writing school letters, so the parents are completely aware that once the child is admitted, we write a school letter, we send to the school. Once they are able to go back to school, we have to also make the school aware that their immunization might not be up to date as a child their age, because when they're going through intense chemotherapy regime, we have to hold things like their immunization so they'll get it when chemotherapy is finished. So we do communicate with the school on that level, but I think we need to broker like a larger initiative at a ministerial level to make sure that this filters down into all of our organizations.
Oh, just a follow-up, final question.
Sure.
From the slide, you had said that one of the ways in which we can partner is volunteer for a childhood cancer organization. Can you give me any detail, anywhere I can check?
I think child cancer organizations.
Right. If there are any that we could partner with. I mean, Christmas is coming up, so, you know, we tend to give back or, you know, just want to join in to see how we can help the cause.
Thank you for that. And this thought is well welcomed, if I can say it like that. We do not have many groups that only their whole goal is only childhood cancer. But we do have NGOs out there that always keep us in mind. And there's Angels of Love, right? That is a well-known group. But more recently, we have seen more involvement with Optimist Club, with Kiwanis Club. And right now, we are looking for the development of a support group that can just dedicate to childhood cancer. Support group that is constituting parents who are driven, members of the public who care to participate and give back in this way. So it's there, the seeds have been thrown out there. We're just waiting on uptake. And we welcome any initiative that you or your associates or any group as such might have. Since I have the mic, I would just like to go back. Can I? Yes. All right. The question about integration in school. So we do all of these things, but then for the period of time that they're out of school, we encourage the work to come, to keep the kids, the minds engaged, right, for those who can. We do have a school at the hospital with a teacher, a learning center rather, with a teacher who is a part of Ministry of Education, who helps particularly in those who are doing that, those different PEP exams, or before it was GSAT, preparation for the level, because the relationship we have with the kids is really long term. They spend, for the first 6 months in a leukemia care treatment, it's about 3 years of treatment, and for the first 6 months they're out of school, right? And for the next 2.5 years they're in school, but they would have, even with that support, there would have been some gaps in their education. So perhaps some of the things that Dr. Riggio said, with the teachers preparing their mind, fixing their mind, wrapping their minds around their student being affected in this way, ensuring that they continue to engage them, and also preparing the other kids for reception, because they come looking different. The hair is gone, a limb is lost. Bullying happens, scars on their side of their head or something, right? They may be allowed to wear a weave. So, hairstyles and so on. Those things, I'm sure there are exceptions within what is going on now in terms of what is allowed at school and stuff. There are some kids who have to have these types of prostheses just to feel okay. Then there's the role of the child guidance personnel within the school who should be aware of this patient, that patient, or that patient, and should reach out and not wait for that child to come to them. The other group are those, especially the brain tumor ones, who, because of radiation, have lost milestones, cognitive milestones then, and so they become slower in being able to remember, to compute, and they may need to be assessed. And that is one way Ministry of Education could help, because it's so hard right now to get an assessment for children who are not going through cancer. There's a long line, right? And for those who try to source this kind of support outside, it's super expensive. And so we find the teachers work with these kids, but don't actually know exactly where the gaps are from an objective testing point of view as much as we'd like. And so we have children who get cancer top of their class, grade 6, and they're put through PEP and they are we're seeding on their original path to the top school, where, whatever we perceive as the top schools in Jamaica. And now they're battling to make it to be among a cohort of kids who have problems with learning. And, that's just because the intervention that's necessary to help bridge them back onto a pathway of normalcy is not as accessible as we would like. So those are some of the things that we would like to see much more seamless as we transition kids from cure back to life.
We're making strides. We're making strides. We're seeking a psychologist at the moment. We have a national strategic pathway. We have developed at the Early Childhood Commission, we have a national strategy pathway, and that speaks about early screening for children, behavioral screening, disability screening, school readiness assessment, and that is at the age 4 level. So we are seeing the gaps, and we're setting things in order, and we're hoping to have some partnerships and more support along the way. It is duly noted.
Thanks. I just wanted to mention from the Ministry of Health's perspective, so we established this Jamaica Moves in Schools program with the NCD registry, and the whole purpose of the registry was to get a kind of census of what was happening in terms of different NCDs in order to now move ahead to support a policy to support children in different contexts. So in that platform and that collaboration is an opportunity for us to now move forward to do some more capacity building. So we work with a focal point from the Ministry of Education and Youth and work through that program. So we have about, I think, 400 now cohort schools that we have worked with. And we recently did a sensitization session with the nurses, School Nurses Association. So it's a large group, and a lot of them, through that platform, you can do much of the capacity building because they are like the first responders and support. And I think that's an opportunity we'll also build on. We're going to actually engage them around sickle cell coming up through this platform, and we'll be looking at different topics. So I think coming out of this, we can move ahead with also looking at cancer as well.
And that's one of the reasons we are happy that we're in this room, and those persons online, we're happy that you are here, because what we're doing is building awareness, and we're trying to build partnership. Because as Dr. Origio said, we all need to be hands on deck, working together for the fight against childhood cancer. Now, we had one question. There was a mention of toxicity of chemotherapy. Does the hospital have adequate protective measures to protect the pharmacists that handle chemo drugs? And most times pharmacists are not handling chemo drugs for us, right? You can go ahead.
Thank you for highlighting that. As it is right now, chemotherapy mixing is done by the doctors on the ward. Not to bash anyone, but our training is not in chemotherapy mixing. We are more in administration of mixed chemotherapy drugs. We have a less than ideal facility as it is right now for chemotherapy mixing in our hospital, but I do know that there are steps being taken to actually improve on that. So there's a partnership being brokered with the NHF to establish a unit which is dedicated to chemotherapy mixing with the proper fume hood and all of that is needed, with proper protective equipment. So as it is right now, our doctors on the wards are the ones that are doing chemotherapy mixing. So I don't want to limit this to just pharmacists handling chemotherapy. It should take into consideration everyone who's a part of the patient management, the pharmacists, the doctors on the ward, the nursing staff who's administering the chemotherapy, the janitors who are taking out the waste from the ward, the PCA who is assisting with changing. So I do not want to limit handling of chemotherapy material to just the pharmacies, but on a global scale to all our healthcare workers.
Yes, thank you very much, Dr. Riggio. Do we have any other questions? I see that we have that one. I'm not seeing one. Great presentation. You spoke a lot on everything that is lacking and talk of financial constraints. My eyes are very good. Can you speak on what the Ministry of Health, but we just answered that just now. So is there another question? And I notice there are several questions. We can scroll down. Is that a question? Are the specific tests done here in Jamaica? I'm concerned about the lab support and turnaround time for testing.
So there has, over the years, we've been seeing improvement in, that's quite a broad question to say, are there specific tests that are done here in Jamaica? Because there are different type of tumors or different type of cancer that will need different diagnosis. For example, a patient who we are investigating for something like a leukemia, we can have initial testing done here. For example, we can have our hematopathologist at the National Public Health Lab take a look at the slides and they can tell us whether or not there are abnormalities seen. We can start with a basic CBC and we can tell if there are any abnormalities in the blood count before we move on to a second level. The flow cytometry lab is available at the University Hospital of the West Indies, so we usually send our flow cytometry there, and whenever it becomes available, we have partnership overseas that we can get those samples done over there. In terms of more detailed testing, where we're talking about things like looking at chromosomal abnormalities, cytogenetics, those aren't available in our system, and it does, we sometimes have to ask for help at the Hospital of Sick Children. They'll provide that information for some of our patients who they deem it absolutely necessary. But on some cases, we also have to ask the parents to how best they can access this overseas. Other things like when the surgeon do a biopsy, and a sample is sent downtown, we've seen improvement in the diagnosis time over the last couple of years, and we've seen significant improvement. So we have cases where we're going from waiting for 6 weeks to waiting for 2 weeks, and if somebody that we need to have direct dialogue with the pathologist to say, can you take a look? We do know that we're short on staff, so we also have to take that into consideration when we are making calls about delay in diagnosis, because we in a public system where most of our sample is going to a central lab with limited pathologists, we also have to think about that in mind, that we won't get it back tomorrow or the following day or within a week time that we see on a broader scale where there are large amounts of staff available. But over the years, we've seen improvement. There are all additional detailed analysis that we may need to be doing on sample, for example, what is called immunohistochemistry, which we don't have readily available, but through a partner with, for example, the Hospital for Sick Children, we can ask for help there, or we have to ask again for the sample to be facilitated in other areas at a cost of parents.
Okay, so Dr. McLean, go ahead. We have a mic for her. And while Dr. McLean is getting the mic, I'm going to have 2 additional questions. And Dr. Riggio, we just want you to start thinking about one call to action. We have our partners, we have our parents, we have our teachers, we have the doctors online. We want one take home from you, a call to action. What are we going to do? What do we need to do? What are we doing together? Yes, Dr. McLean.
Hi. Yes, thanks again. So everything that Dr. Riggio has said very clearly and nicely. I think we have mentioned Hospital for Sick Children a few times. The whole helicopter plan of that partnership with Sick Children, Hospital for Sick Children, was to trigger us into build capacity and trigger sustainability. So the vision is not for sick children, hospital for sick children, to continue to do these immunohistochemistries and these additional tests that we need to make the diagnosis. The vision is that it should trigger us, Ministry of Health level, to see how we can budget to include and improve the cadre of tests and investigations that we do, one, how we can look at our human resources in terms of the specialists at NPHL and pathology to see how we can engage and keep pathologists interested in working for the government so that with the turnaround time can be reduced that way. It's certainly, even though it has improved, and that is true over the last 10 years, there's been great improvement, there's still a far way to go. So I think that question was a wonderful one, and I think it should segue into a trigger message to Ministry of Health to see how we can pitch higher as we have been supported so long by SCI.
Excellent. And that kind of answers Mr. Brady's question. He was saying, is there any plans for training posts? Though we will not tell you if there are plans for training posts, we are here today to demonstrate that there needs to be advocacy for all of the things we mentioned. So please share the link, spread the word, because we're trying to advocate for improvements, continued improvements in childhood cancer awareness. And I think we'll take the last question. And it's gone? It's there? Okay, it's expanding. All right. So that seems like a long question that we could probably answer in the chat. Is there, my son has cervical lymphadenopathy. Yes. 2 general practitioners. And is there a summary? ENT does not think we need surgery to remove the tonsils. Is there anything else we should do? So what we're going to do is we're going to look at that question in the chat after, and we'll answer that question. And then we're going to Dr. Origio's take-home point. So we're going to stop there. For those persons who want CMEs, we're going to share the link in a short while. You're going to receive a link for a post-test. And on receiving your link for your post-test and completing your post-test, you will receive your CMEs. So invite a friend, share the link with a friend, and we will continue. Now, final words from you, Dr. Origio. Talk to us. Get us to move, get us to act. Your presentation was excellent. We now know what we need to do. We want to envision what is our role, what is my role in ensuring that I am an advocate and I am doing something towards childhood cancer awareness.
Okay, so we want to start with basically learning to identify those early warning signs of cancer in our children. Cancer is not a death sentence, but it is definitely a life-limiting illness. If identified early, it can be treated and offer a high possibility of cure. It does entails us as doctors, primary care providers, parents, teachers to all come on board, identify those children that we think are having symptoms that are concerning, refer to the appropriate medical personnel, seek medical attention for anything that you deem concerning. Symptoms that are not going away, seek medical attention over and over again until you're completely comfortable that your child is fine. And we call on the non-governmental organization to come on board, partner with us as we try to, as we carry out this fight against childhood cancer. There's a lot that needs to be done. Speak with someone, speak with a parent who's going through this, speak with the doctors, come to the hospital, visit our wards, and come on board and see how best you can support our children.
Thank you very much. Thank you for those online. Remember, you're going to get your post-test now. And we thank you for joining us this afternoon, and we wish you a good evening.
Inside? Yes. What? Don't speak in your microphone is on.
Those of us who are in the link should get the CME automatically. Should I send it over Yes. Yes. Okay, yeah, I do. So my car never make half an hour for the
I don't know. There's people here and my only get you so far. You go. Okay, you not move there for me. Maybe I'm disgusting. Oh God.
That's your name. That's what I may have written. Today I written
6:30.
I'm patient. I'm not feeling of it. That's right. You see what I got for my work. Come from the world and the feeling.
So you want him right now?
Yeah.
And then the gym, I done 31.
Y'all going there, Andy?
What's your favorite? Let me try to get my.
Oh.
Guys in there.
Yeah, come. May come in a photo. It's gonna go. In the chat now. Siya, may get mo pa ni signal. Wala.
Yeah, your voice.
Okay.
Hello, can you hear me? This is Dr. Dunkley Thompson. We are still not able to access the post-test link. It says that it can't have any more submissions. Can you hear me?
Right.
It says the form is not currently accepting submissions and we are to check back later.
I got onto it and finished.
What was that?
I got onto the post test and finished.
I am not sure what's happening. I've been
Can try
trying.
again.
All right,
Good
it
one.
says sign in.
No.
Let me see.
You go to this one. So no worry, when I come back, it's a little Medicaid.
Yeah.
But you can relax.
Okay. The post test keeps saying can't find your Google account. I don't have a Google account. When I put in my email, which is a Hotmail, it doesn't come up.
Johnson. Yeah. Betsy, yeah,
I think the problem is that it's a Google Doc, so it might be coming up in your Gmail account easier than in any other Gmail, any other email. It's a Google Docs.
Yes,
so
I know,
that
but
might be your
if
problem.
you don't have a Gmail account, what do? My account is Hotmail. That's why I'm asking.
There.
All right, let's see this new one that was sent out, if this is any better. No, it's the same thing. You have to sign into Google. Is there a way to not have it as a Google Doc and something else? There are several people saying it's not working for their Hotmail address either, so I'm not the only one. Is there anything that we need to do? Is anybody there? Can you hear me?
There are 146 persons on, so I'm sure persons are
Good
here.
evening. So I just completed the form and it submit and all went well. So I'm not sure what's happening on your side.
Do you
Because
have
we
a
don't
Google?
have the
That's what I'm asking. Do you have a Google
right.
account? Because we don't. I have a Hotmail account. So when I put in my Hotmail email, it says that I couldn't find your Google account. So it doesn't go any further.
Right. It says indicates the required question, and it is telling me that it's my email address that is not.
Is it working now?
I'm thinking that the same platform you use to register and receive the link in the email, I think that's the same email they'll use in the system.
No,
So I'm
but
not
my
sure.
email
No,
has always
it's
been
not going to be the
Hotmail.
same email. Question, are you now able, because I'm seeing responses of the about 93, 94 responses now. So some person are getting 94.
Some persons have the Google account.
Because
Those
they
who
have
don't,
Gmail,
Google
that's what I'm
account.
saying.
Right.
But what we did was we removed the need to verify your email address. So even with the new link that's shared now, it's still not working.
No, well, let me try it again.
I just shared, try the latest one.
No, it says sign in. It says sign in to continue. And it says use your Google account.
It still says sign in?
Yes, it says sign in. And it says use your Google account.
Does it give you the option to switch accounts?
It tells you to switch account.
So when you switch account to see if you are able to sign into another.
You're not able to put in the Hotmail. It says to switch, but when I tried put in the Hotmail, it did not take it.
I don't even see switch. I see create account, but I don't see.
It said switch. There's a switch there for me, but it is not taking the new one that I put in.
Where do you see switch?
I actually completed already. Just underneath. All right. I have a Gmail account that I don't even use. I don't even know how to get into it. So that one came up, and just underneath it, it says switch account. And I
I'm
thought
working
switch
on
account.
another form for you right now. And let's see if it will work. That will not require you to do.
The thing is, the form comes up, but before I can go on the form, it says sign in to continue. And it says to fill out this form, you must be signed in. And then when you sign in, it talks about use your Google account.
All right, so what I'm trying to do now is to not have you sign in.
Sign in, yeah, that's what
I'm. Won't collect any. The only problem with that is if you make a mistake. So I'm going to send, and persons only use this link that's coming now if you had a problem with signing in. And let's see if that works for you.
Okay.
That one that was just shared.
All right, that one that just shared said this form is
This
not
form is
currently
not currently
accepting
accepting
submission.
It's going,
Please
click on it
check back
again.
again later. And
Click
it's a please, and it's a see previous
previous
responses.
responses. Yeah.
I don't know if
Click
it's
on it. Click
What
on
am
it
I to
again
click
because
on?
click on the same link because I'm seeing when we try to turn on automatic certification on that form, it turns it off because it
No.
seems to be wanting verification. Okay.
This is
Yeah,
really.
it's not allowing us to give you automatic certification without.
So,
And it when I click on that, it is giving me everybody's response.
yes.
Yes, this is futile. I really don't need.
What you can do, you can email.
No, it's not.
I'm not going through. It's
We need-
really wasting
I don't
time.
think, yeah, I think we
All
need
right.
to
Have a
stop
good night.
all right. Thank you.
Okay.
Same to me because I do have another meeting to attend.
Yes, it's
Okay then.
wasting time. Yeah.
Sorry about that. But I'm sharing an email address that you could go ahead and you could send me an email and we'll try to get some CMEs to you. And so that email address was just shared. If you copy that email address, you can email me to let me know that you had difficulties and we'll try to get the CME sent to you. And apologies. We had quite a few difficulties with online today. But once you email that email address, we'll try to get the CMEs to you. Thank you, everyone.
Somebody looking at your face. Oh, sir. In the incidents are going to die. Then there's some man will have gun or weed and time. There's no way a young man that is grown will behave like that. Man couldn't turn an indicator say matter. Christ, God. That me know what they know we know young people there. You know what they know we're not with them. Into water. Jesus Christ, God Almighty. So just in time to come and catch. Fill out this and I don't forget my certificate.
All right, so again, for those persons, the link that was just shared, that is the link for those persons who have a Gmail account. If you don't have a Gmail account, you can send an email and we'll try to get your statement to you. So please go ahead and take down the link. We're going to close it now. And thank you all very much. Have a great